So we are excited to,
Does the word haze come to mind?
only to some people.
But that's against the law now.
Yeah, otherwise. Yeah.
You guys amaze me every day. I just never know what's gonna happen.
Now you know how we feel. There we go.
Ooh. Okay. So back to
We
the
were all here
agenda.
till 8 o'clock last night, so we're a little snappy.
Yeah, back to the agenda. Yeah. Would anybody like to add anything to the agenda?
Your name's there.
Anybody like to move the agenda?
So
Madam
moved.
Chair- Oh, okay, I second that agenda.
Well, that was tough for
Yeah,
Yaffa.
Yaffa, tight
First,
even.
second. All right, how about the consent agenda? Would anybody like to pull anything from the consent agenda, or are we good with it?
I make a motion to accept. Sorry, Gary, I'm going out
Sorry.
of order.
Heidi moves and
Support it.
Commissioner Gamble supports. Thank you. So that leads us to our next agenda item. I gotta make sure I got this right. So we have Greg Bernier with us, who's gonna give a report on the Wilderness Outpatient Treatment Program, which we are excited to see and listen to. You're always a pleasure to have.
Thank you.
Greg, thanks.
We'll see.
Yes.
Oh, no?
Yeah.
Oh.
Yeah, always, but especially right now.
Just let us know.
Normally we have music.
I put you first,
Come
Greg,
back
to take the
later.
pressure off of me.
Thank you.
Hey, Greg, I put you first to take the pressure off of me.
Thank you very much.
Smart. Yes.
Too relaxed.
5 more minutes.
Thank you.
Well, this is just a little overview of the program and how it compares to the rest of the state. And, here you go. What the drug trends are in Minnesota. Outpatient clients, at the top, I've just shown you what the numbers are since 2008. You can see it's always pretty steady. It's around 20. And the way I measure this is just the number of people actually in outpatient. Some of these are people who go away to treatment and then they come back here for outpatient as kind of a step down. Some are people who are doing treatment for the first time. And so we try to go with, if they're appropriate for the program, the least intrusive, I don't know if that's the right word, intervention first to see how they do. In order to stay in outpatient, they have to demonstrate an ability or at least a desire to abstain. So for instance, right now, we have 7 people in group, but last 2 weeks ago, discharged somebody who'd been in group for 3 sessions because she just couldn't abstain, and now is being referred to inpatient treatment. So we get kind of a whole range of people that go through outpatient. Some stay the entire time, some get referred, some leave, some get kicked out. So in the group right now, we have 4 women and 3 men. We have 1 person from Grand Portage. What? Oh, okay. Okay. I've been reeled back. Let's just see.
Before you start naming names.
The people in group, they don't care who knows, but
Yeah.
and that's a good thing. When I started here with Harry Swift, Harry described the population he serves as mostly male, Scandinavian, with lower education. It was really rare to see anybody with a college degree. Women were rare. And now you can see we are pretty close to what's happening in the state. There are 4 women in the group right now. We have, over the last, this year, about 43% of our clients have been women. So that has changed a bit. Race, the reason or ethnicity, I mentioned that because we have such a good relationship with Grand Portage. We get quite a few referrals from Grand Portage now. That's changed since I began. Again, that was rare. This has a lot to do with the people in Grand Portage who are really focusing and care about their clients, and they have a city councilor there now doing evaluations, so that's reduced the load at our end for assessments and evaluations. But we get a lot of referrals, and it's higher than the state average, of course, because of our proximity, but also because of the cooperation of the tribe. Primary abuse problem, another thing Harry would say is it's always alcohol, but that has changed in a way. When people come to treatment, part of their assessment is a list of the drugs they've been involved in, what's their drug of choice. In the past, that used to be alcohol always at the top. Now that's changed, and it goes through cycles. Right now, we're seeing a lot of meth use. 2 years ago, it was opioids, painkillers. That just goes up and down, I think, as the availability is here. The people are reporting less opioid use right now, but we're actually seeing for the first time in the last 3 years people who are using heroin. We've never seen that before. And now we are seeing heroin use. And I think that's underreported by clients, because when they're in treatment, when they've been there for a while, then they'll say, well, I did use heroin at some point or other, but there's a lot of our clients are referred by probation, and at least in the beginning, they just don't want to get in any more trouble. And so they'll admit to what's documented, but resist revealing what nobody knows about. But as they get sober and begin to work the program, they become more honest and more willing to reveal that. They learn that probation isn't going to put a wire on them and try to capture whoever's selling it. They're no longer afraid of getting in any more trouble. They realize that our focus and probation's focus is to help them get better. Mental health services. The mental health providers in this county are real easy to work with. They're available. A lot of clients will have mental health diagnosis, especially if they go away to treatment and come back, they'll have been diagnosed with something. Often it's depression. Sometimes there will be a personality disorder that isn't really diagnosed. They'll say personality disorder, borderline, for instance, NOS, not otherwise specified, because they see traits of some of that behavior, but they know the person is only recently getting sober, so they want to wait to see if these symptoms persist after they've been sober for a while, and often they don't. But again, there's a stigma with clients, a real need to protect themselves, and so they will be reluctant to talk about any mental health issues they have because they just don't want more to do. And there's some stigma with some of these diagnoses, especially the personality disorders, and so they don't want to mention it. But again, as they're in treatment longer, they'll become more open. We'll refer them then to a mental health provider here in town to have what's called a diagnostic, to just see if there's anything going on. The way we present this to the clients is not by agreeing to go see a therapist for a diagnosis, you're not agreeing to now being in therapy for years. Just go there and talk to them about the stuff that you've been talking to me about. See if they can identify something they can help you with, and then you can decide. It's always, we always try to couch it in that kind of language. You decide what to do and see if it'll help you. And most of the time, people, once they meet these providers, in this town, we work closely with HDC, meet once a month with them regularly to discuss clients. But there are other providers in town who work with our clients, and they are so good at creating this atmosphere of trust and care that the people will often realize quickly that this is a person who can help them. So we're really lucky in this town to have, we don't have very many, but the ones we have, we're really lucky. They're really professional and know what they're doing and really communicate empathy and caring. And, it's not always the case. And right now in our group, self-referrals, about 20% are people who have referred themselves. It isn't always alcohol, but in this year, the self-referrals are alcohol. And they do well. I had somebody ask me once, what is treatment? What's your goal in treatment? What are you trying to do with these people? And I asked that question once years ago of my supervisor after a really kind of brutal group session where somebody walked out, people were angry, just kind of emotionally exhausted after that. And I wondered, what's our purpose here? What are we trying to do with these people? Because it doesn't seem like anybody's responding. And what I was told is the purpose of treatment is awareness, to help a person become aware of the connection between their alcohol and drug use and other problems in their life. And that made a lot of sense to me. And so self-referrals are people who have already kind of reached that stage of change. The stages of change are pre-contemplation, where a person just has no idea that there's any connection between the trouble they're having and their drug use. I was one of those people. I was absolutely one of those people who thought, my alcohol use isn't creating the problems, I'm drinking to cope with the problems. And if you'd asked me then how long I'd had a drinking problem, I remember this just so clearly. It was about 4 or 5 months. That's how long I had a drinking problem. It's only been a problem in the last 4 or 5 months. It took me, honestly, several years before I could even admit to myself that I've had a drinking problem since I was 25 years old. And I wanted to be sober, but it was just so hard because to admit I was drinking every day since I was 25 meant for 25 years I had alcohol in my system. Probably all the time. I can think of one trip to Washington, D.C. We drove, and of course I'm married and I have kids, but I've got to keep this a secret from my wife that I'm drinking every day. So we're on the road and I can't drink, and I can't wait for us to get to a motel so I can tell my wife I'm going to go get gas, so I can really go to the liquor store and put down a couple of beers. My wife knew what was going on. It was hard for me to be honest about that. And so the purpose of treatment is to help people become aware of the connection, and the self-referrals of people who have gone through that pre-contemplation stage, where they're thinking maybe there is a problem, maybe there is a connection. The self-referrals are in the preparation stage. They've decided they're going to do something about it. They don't exactly know what to do, so they come and see someone like me to get some suggestions. And next week, or maybe 2 weeks from now, we'll have, I'd say 3+ that people who are going to enter treatment. That's down to 2 already. But one of those people is a self-referral also. Any questions?
Thanks. Thank you, Greg. Commissioner DeKirk?
So the numbers in Grand Portage are not increasing because there's a problem that's increasing. It's because the relationship that's been built with our public health is a better program.
Yeah, that's what I would say.
Yeah.
For sure, I would say that. When I talk, especially as I was rehearsing the speech, I was always saying we do this, we do that. And that's because even though I'm kind of the one person in wilderness, this is a we thing. I couldn't do any of this without the cooperation of the mental health people, without Grand Portage, with Grace, Allison, and Yafa, Josh and Sue before me. The working relationships here are so good because of the people we have here.
I just didn't want anyone to walk away from your presentation thinking that there's a new problem or
No.
that something's happening, so, thank you.
Yeah, no, it's not a new problem, it's, people are getting help. That's what I think.
Commissioner Gamble?
Thank you, Madam Chair. Thank you, Greg, again, for what you do, and it's good to hear the stories. We have the statistical, but the connection to people's lives and our staff, and your affirmation of their work is an important thing for we as commissioners to be aware of. With the statistical numbers that you provided and the significant increase in meth that we see, which on the state average is so much higher,
Mhm.
I'm just wondering if some of our, to the extent that our treatments are actually driving trends. And what I mean in that regard is sometimes to try to mitigate some of the issues, we come alongside and we provide some of these drugs, thinking that it's a better course. And of course, people that are desperate, if they can find avenues in which they can meet their human need, that's why I asked the question, if we, in our treatment response to human need, are driving trends.
Well, the numbers that I have are, reflect why they were sent to see me. A lot of these people are probation people, so they are sent to see me and they've gotten in trouble for alcohol. The crime or the offense is alcohol related. So the meth people are people who came to me because the offense was related to meth. So that's the number I see. What I believe and know is that they're using other drugs. All the people in treatment right now, they're all alcohol users. They got in trouble for meth, they got in trouble for heroin, or or even pot. They're all using alcohol. The heroin users are using meth. The meth users are using alcohol, they're using opiates at some point. I don't know about the heroin, people are just so quiet about that if you don't know ahead of time. So it's, it's sort of, it depends on how you measure it,
In my experience of having early in our married life, we're house parents in a home for drug addicts, all related to heroin. And so, the response, society's response was to try to figure how do we mitigate. If one is more deadly or threatening than another is, maybe we can address this need by trying to dovetail between using something like meth and get them off heroin. And my point is that if our assessment of a situation and that response to that assessment is something that drives trends because of accessibility, that's sort of where I was going with that. And I was just making an assumption born out of that, previous experience. But
Well,
and that might not be as true in a rural community as it is in an urban area.
right.
Yeah.
There's somebody who's going to treatment right now and has a prescription for Xanax. This person's drug of choice is alcohol. So both of these are depressants. Person has, just as an example, I'll make this up, has more than one doctor. One doctor for the Xanax, one doctor for the medication for depression. And they don't know each other, these doctors, until now, because this person would reveal to me these prescriptions and going away to treatment, get a call from treatment saying, well, this person can't come with Xanax. And but the person has agreed to go off the Xanax and we're getting treatment. But that was, clients see it this way. Clients do. The people involved with heroin and meth, if they've been abstinent for a year, as an example, and you ask them, how long have you been sober? They'll say, I've been sober for a year. And then as we go through the assessment, we'll say, okay, let's talk about alcohol. We'll agree, first time you used, when's the last time you used? Oh, I had 2 weeks ago. I had some, and then the pot, about a month ago, you know. But in their minds, because they're no longer shooting up heroin, they really are in a better place, but they just don't, they see that I'm better off using alcohol or pot now, and I really don't have a problem because that's how I have fun. The pot users, people get in trouble for pot are always involved with other drugs. I've never seen somebody whose only drug of choice is pot, ever. But that's what they got in trouble for. But in treatment, we find out about all the use. We go back to their childhood and see, are there any times in your life when you've been using alcohol or any of these other drugs for a long period of time? And that's what we'll find, you know, they switched drugs. They used alcohol a lot when I was in college. Now I got a job, I started using speed, got into meth. Meth just ruined me. Now I'm using opiates, or I was using opiates, now it's just alcohol. And so in their heads, they're sober, because now we're just using alcohol. But, and they, you know, it's innocent, and they're not lying. They really believe this. This is really their truth. But what we try to teach people is that all the drugs are all dopamine systems. It doesn't, every mood-altering substance you use, the dopamine is a neurotransmitter related to pleasure and reward. And all the drugs kick the dopamine system harder than real life does. And so they're still looking for that dopamine rush. And we try to educate them that this is what your recovery is really from, is to recover from ready euphoria.
Instant gratification.
There is euphoria in life, but it's not every day, you know, and you have to learn to need. And I just read an article somewhere on my iPad, that's where I read it, and it was 6 things they don't tell you about sobriety. And the first one was, the days are just so darn long. And you know, and that's what we deal with in treatment. The days are just so darn long because when you're using, it takes up hours and hours every day, and you aren't doing anything else. That's what you're doing. And now you abstain, and now you've got all this time. Number one, they realize that. But number two is they're starting to feel these feelings that they may have originally started using to get relief from. So now they're dealing with emotions that they haven't had to deal with. Now they've got problems that they were ignoring. You know, it's April 12th, and now I've got to get my taxes done. In the past, I just wouldn't do it. Now I'm feeling like I got to do it. My kids, who I always thought were taken care of because they had shoes and clothes and food and lots of toys. Something wrong here because I haven't been giving myself emotionally to my kids, and I got to spend time with my kids now. And that is so overwhelming for people who just begin to get sober. That is so hard. And it takes, gosh, I don't know, a year, I would say, to get used to living life without euphoria in your pocket and dealing with the normal things, you know, normal, and feeling good about it. And that's why they need so much support. The trend, one of the things I didn't put in here is the trend in treatment is to keep people in treatment longer. When I went to treatment, it was 28 days. Now this is 13 years ago, 14 years ago because I relapsed. At the end of 28 days, I didn't want to leave. I wanted to stay. I went in there kicking and screaming, but I loved it when I gave myself to it, and I did not want to leave. And they told me I had to come back here and face the music. I said, couldn't I go to Halfway House? No, you got to go back and face the music. You got to deal with this stuff. And I came back and I relapsed. I walked out of treatment thinking, I just did not want to be an alcoholic. I didn't want that, and so I left treatment thinking I'm not. And I was going to try it again. And I did try it again, and it didn't work out. But now the trend is to keep people in treatment longer. because it really does, we know that the longer a person is involved in some sort of organized program to help keep them on track, the better the outcomes are.
Wow, awesome. Commissioner Moe and then Jerry.
Thanks, Jen. Thanks, Greg, for your work. You know, I know a lot about it, and I'm very grateful for your leadership. A lot of the challenge for us, you know, in the county board is we direct resources to things, and we want to make sure that we're trying to do the best that we can with those resources. And can you give us a little more information about how often do you see people back in wilderness treatment? You know, what's the longer term picture for most of the clients that you are in contact with?
This past year, we've had 3 clients return. They've been in outpatient. Last year, they were in outpatient, got discharged for using again, not being on. I tell people in group, I'm not going to kick you out if you use again, if you're honest with me about it. But if you use again, you don't tell me, then it's automatic out. And then I refer them to inpatient, and then they come back to outpatient. So 3 of the people in this number for this year are people who were in treatment last year, went to residential and came back to outpatient. And I'd say that's typical, pretty typical. It hasn't happened this year, but sometimes people will go through residential, outpatient, aftercare, and have a period of sobriety, and then drink again, have some kind of big event. We might start with outpatient again, because they've shown they could be sober for a while. And we know what happens. You know, this is an illness, a relapsing illness. It's one of its features. It's like, and it's hard. It's always a struggle to get some people to accept that this is an illness, but it's the model that currently works. And relapse is part of it. So in treatment, I want them to just be honest about it. Don't lie about it. And we can work with it. But, you know, and then maybe some people have a year and they'll be off probation and they'll get in trouble again and they've relapsed. And we know that it's, you know, it's something in that really long day went wrong. That's something there wasn't being addressed. Maybe when they left treatment, they did learn how to address all their triggers and vulnerabilities, but something has changed. That's what's happened. Now something has changed. Something else has become a vulnerability. So what is it? You know, is it something we can help you with in outpatient? If we can, we will. But if we can't, we won't. You know, it might be a bigger problem. Sometimes people just go back to drinks. They might be like me, which they just didn't want to be an alcoholic. Thought now they know everything. It couldn't possibly happen again because I don't want it to happen again. And I can control this. And then they find out they can't. So that's a revelation that, yeah, I really have this. It's really true. I really have this. It really is an illness. I didn't want it to happen. I just lost control quickly, and now I've got to. Maybe that's what they have to address, just the willingness and acceptance. But in fact, that's often the thing. That's, you know, it's the first step in AA. It's the first thing we address in treatment is acceptance and surrender, you know. And we do that by the work they do, you know. What has happened, you know, so they can come to that conclusion themselves and hopefully be honest about it. Really encourage people to be honest about their doubts. And they like that. People in treatment, they like it if we say, don't tell me what I want to know or what you think I want to know. Tell me the truth. You won't get any punishment for it. And then you hear, I really like drinking. I really want to drink again. And I don't know, you know, if I get off probation, I might just go back to using. And they say, yeah, it's hard for people to think so far ahead, you know, especially I have young people in group now in their 20s, and thinking of a lifetime of sobriety is just, they can't do it. They just, do I want to be sober my whole life? And they don't, because, you know, in this stage, it isn't what they want. And so we just tell them, again, this great AA phrase, just be sober today. Just decide to do it today and see how you feel tomorrow. And that's something you can handle and relate to, you know. And then as they get more sobriety, their lives really do improve a lot. The people who get on board. I've got something, I didn't want to talk about it today, but I wanted to give it to you. It's a handout I got from treatment court. When we're going to begin, excuse me, recovery court in September. And the recovery drug court team is the judge, prosecuting attorney, defense attorney, probation, myself, and then when clients who are in drug court have a mental health provider, that mental health provider is a team effort. I forgot what point I was going to make. I really did forget.
That's okay. It'll come back,
We
I'm
do it all
sure.
the time.
You know, I was worried about this last night too, because I would say I'm a little bit ADD, but really I'm a lot ADD. And I'll have a thought and it'll be really great and I'll be thinking about it and then I'll have a better thought and I'll go to that and I'll forget what the first thought was.
I can relate to that.
But we're starting drug court and it's going to involve, we might have 6 to 8 people a year. These will be high risk, high need people. High risk is a high risk for offending again. In my world, it's a high risk for using again. High need is that they don't have jobs, education, money, place to live. That kind of thing, that their recovery environment is bad. But they'll be involved in drug court for a year, every 2 weeks in the beginning as they go through phases, then once a month, hearing before the judge, random drug tests every week. And every phase, they get closer to graduating.
Awesome.
And the probation and the attorney and the judge are really on board. We've had 3 of our clients involved in sort of a made-up drug court this past year, where they do get random tests and they see the judge every 2 weeks, and they just graduated. And the judge is very supportive. The attorney is very supportive. They come in with a dirty EUA. They don't get thrown in jail anymore, where they get encouraged to keep working on your treatment program, try to get that UA clean. And the judge is telling people how proud he is of them and giving them another chance. And all these people are doing better. So drug court really works.
Jerry.
Thank you, Madam Chair. Greg, how are you feeling about the other treatment resources, residential and detox, in terms of availability and the working relationship that you have with them?
Now this is Jen Rue, who's the CD case manager. I make a recommendation for treatment and Jen Rue places them.
Okay.
We're really lucky to have Jen Rue, because she has working relationships with a bunch of programs. She can call and just say, this is Jen, and they'll talk to her. And really happy with that relationship. Detox, that's a hard thing up here. They have to go to the hospital. If they need detox, somebody has to provide transportation. The police will provide transportation if the person refuses to go, but if they are willing to go, then they have to find their own transportation to Duluth, and that's a long trip.
But it's available if it's needed.
And it happens. Yeah. Families take their person to detox. It's just a long trip, but people are used to driving to Duluth, and it happens.
I just wanted to say, over the years, I've just admired your work, and you make it so clear for people that don't have that struggle to understand it. And it seems to me, using this chronic disease model, I think if any of us got diagnosed with a chronic disease, it's like, what, me?
Yeah.
Oh no, I can cheat on the sugar a little, or whatever it is.
Yeah.
I really think
I don't
that's-
have diabetes.
Yeah,
It's kind of
exactly.
human nature, to
Mhm.
do that. And I think
Absolutely.
that's why you see all, the recidivism that you do see.
Yeah.
But that doesn't negate that maybe much like a woman in an abusive situation, you leave and you come back. You know what I mean?
Mhm.
But you
Yeah.
get there,
Yeah.
Yeah, it's a process.
thanks to your programs.
Thank you,
Others.
but really, yeah, I appreciate that so much, but the program really is all these people.
I know.
You know, it really is. I mean, I talk to people kind of doing my job in other places, and I'll describe, for instance, Jen Rue, how I can walk 30 feet, and that person, she'll make the call that day. And in bigger metro areas, they wait a week or two sometimes, just to get a response. The doctors here, we meet with the doctors every 3 months. It's a regular meeting, first Wednesday of the month at 8 o'clock. And just sit down and talk about patients we have in common, and then trends, things we see. You know, I didn't set that up. Harry Swift and Steve Board set that up. That's unheard of.
That's awesome.
But boy, I'll tell you, when a doctor calls, I call them right back. And the other side is, if I make a call or we make a call, we hear from them that same day, usually, you know. Same with the mental health providers. Boy, they call you back that day. And they call with a lot of information. So people are lucky. You'd think up here in the corner of the world, it would be harder, but I think it's actually easier. You know, it really is. The relationship with Grand Portage. I talked to a counselor from the western part of the state, and I don't know what we were talking about. I mentioned the Grand Portage, and he wanted to know more about that because he's saying just how hard it is for him, where he's working to work with the tribe there, because there was so much suspicion, and there's a lot of prejudice, of course. But here it's different, and that's, you know, thank God for Grand Portage, I think, for both the Roger James and Roger Linehan and Geraldine. It's just different up here. So my job is actually, I think my job is easy, to be honest. I don't like the paperwork.
It's gotta be something.
But I don't like the paperwork. I really don't like the paperwork.
Paperwork is a disease.
Yeah, yeah. It's a culture
Yeah,
disease.
it does.
Yeah.
So you
I
want
make a living on paperwork.
I love it. Some people love paperwork.
So I'm just gonna give this to you, it's just what we got the first day of training, you know, and if you look through it, you become more familiar with why drug court, in our case called recovery court, works. Really, just better outcomes for clients.
And I love it that you call it recovery court. That's a
Yeah.
beautiful, that's a beautiful custom twist
Yeah,
to,
that was the
Yeah.
judge's idea, actually.
that's awesome. Yeah.
We're lucky to have him.
I don't like filing, but I like paperwork.
Okay, you do? Oh, you do, of course you do.
Thank you. It's a paper world for some
I
people.
love trees, paper.
Yeah. Yeah.
Yeah.
Thank you, Greg. Are there any more questions for Greg? And I just want to apologize. This is the first time that this board has been on camera, so I just thought that I would introduce two of the county board people are on camera a lot, but we have Carla Lapointe and Jerry Lilja that are with us today that are part of the Human Services Board, that just for the camera might, and I didn't fully introduce Joshua. I just said Josh, our new Joshua Beck is here today, and we also have Grace and Allison and Yafa here today. And Yafa is next on our agenda, and I think, unless you wanted to introduce her, Josh, I'll just
No, that's
say,
fine.
are we good to move on to the financial?
My favorite part?
Yes. Yeah. And standing around and Josh, we have two Joshes, yeah. Yeah.
I suppose we didn't tell these guys they were live today, did we? Do you know
No.
you're live?
And we didn't, yeah, that's the other
We're
part.
alive today.
Yeah.
I don't know if I should wave to the camera.
Yeah, say hello, they're watching us.
Streaming worldwide.
Yeah, they're recording, but we're live.
Oh,
Yeah.
And I didn't get to say goodbye to Greg, but he did, he had a great,
He's
that was a
going to
great
save the world.
presentation. Yeah, he's busy, he's gotta go save the world, so we're gonna move on without him while he's out there saving the world. Yafa.
I'm sitting at the other end of the table this morning since
Oh, yeah, you're performing
Sarah
many
as well.
tasks.
Yes. I did used to take minutes at city council meetings for the city of Grand Marais over 20 years ago. So, sort of remember.
You
how
can
to
do both?
that. Yes. I don't have a specific little report on the CD areas this month. I've been trying to have a report on who's ever doing the presentation, with numbers behind that. I didn't do that this month. I did pass out, in the attachment, you have a narrative for July where I talked about some trends that we're seeing. And that in the budget that we put together for 2017, some things where we're over budget this year, we've budgeted more for next year, trying to address trends we're seeing. One of the things that is going to be affecting revenue for the rest of this year as well as revenue next year is the state sets targeted case management rates, and that's rates for specific clients to meet certain criteria that social workers work with in areas of child welfare, children's mental health, adult mental health, and vulnerable adults and developmentally disabled. So all those different categories, if you meet certain criteria, we get revenue for targeted case management, so case management working with those specific clients. And every year the state gives us our rates in those areas, how much reimbursement we're going to get, and it's based on client numbers, hours that we're working with those clients, and overall costs, overall social services costs that we're reporting. And as a result of that, for July 1st of 2016 through June 30th of 2017, some of our rates went up, some of our rates went down. And one of the categories where we have a lot of activity is in child welfare targeted case management. And we had a 37% increase in cases and a drop in hours that can be attributed to vacancies between when staff is left, between that and when their replacement gets hired, and also someone was on maternity leave last year. And so our rate went from $470 per client per month, where we've done case management, down to $214 per client per month. So that's less than half of the same reimbursement rate. So we also, at the same time, had a major increase in clients eligible for those services from last year. So my projection of number of clients was too low, and my projection of what our rate would be from the state was too high, and the net effect is the drop in revenue this year is less than it otherwise would be, which is financially good news, but in terms of number of clients needing service, not good news. So net effect is only going to be $12,000 under budget this year in that line item, as opposed to more like $26,000 under budget it would be if we didn't have additional needs for those services. So once again, I'm talking about numbers, but there's also people behind those numbers in this case youth. So that's difficult to discuss in terms of effect on budget.
Yeah, if I may, Madam Chair, if I could just interject here while you just talked about that drop in rate. Reading this, the basis under which rate is established hasn't changed. It's just that the metrics that is used to determine that rate, given the fact that we have fewer hours invested in those things, that when the state reevaluates that, it sets us based upon that criteria, which arrives at this rate.
Right.
My question is that, given the circumstances that, you put forward, that moving forward, each year when we see this review by the state, we will see this affected by invested time in these cases. And so that period of time, it's an annual assessment, correct?
Right, and it's halfway through our fiscal year each year.
Yeah.
So when we've budgeted, we don't know what it's gonna be for half the year.
Yeah. I mean, typically when you're looking at trends and trying to project, you look at what's consistent in a trend and then what's not consistent. So when you have situations that you expressed, like maternity leave or other things that are taking and changeover in staff, if we feel that we have staff in place and we know that we're going to be consistent in that, then we can look at the trends under that scenario, so to speak. And I mean, this is as complicated as it gets trying to project budget in public health, human services, but
Yeah, and the sheet that we get each year has the rates for the previous 5 years, and in the child welfare targeted case management, the rate that just ended was significantly higher than it had been in any of the previous years. So now the rate we're at now is closer to what it had been if you look at it on average. We also get every year the list of all the rates for all the counties. And so one of the things I did is I looked to see where we were in relation both to our regional partners in Lake County, Carleton County, Itasca, Coochin, as well as St. Louis County. And St. Louis County is much larger than everyone else in the region, so their numbers are very different very different in terms of the gross numbers they're using. So we might have 10 cases where they have 1,000, something like that. But the other counties are much closer to our number of hours and number of clients than St. Louis would be. And so that's interesting just to look at it in that way. And so child welfare targeted case management, we went from $470 a month down to $214 a month. The lowest in the state for this coming year that started July 1st was $117 a month, so that's half of what we're getting, and the highest was $837 a month, twice of what we were getting, almost twice of what we were getting last year. So it's hugely varied, and lots of people are in the 2s and 300s. And it's sort of like throwing a dart. How many clients are we going to have?
Yes.
How long are they going to be our clients for?
And are they MA eligible? Because that's the other variable in pulling down these dollars. The person has to be eligible for medical assistance, and there's a greater number of people, not to interrupt or anything, but there's a greater number of people who are eligible for MA these days, which can be good, but many people have private insurance, and we cannot bill for the work that we do, even if they meet criteria. And the criteria is set forth by the federal government, and there's various things that we have to be clear about in order to bill for and to capture these funds. So it is very unpredictable, yet a child who has depression in Mankato is probably no different than a child who has depression in Grand Marais, but yet the rates might be totally different. And in fact, we have fewer resources here, so it's not based on anything related to the reality of treatment access. It's just a formula, and it does make it really hard to budget because we never know how many people we'll serve and whether or not they'll be eligible and that kind of thing. So it's a challenge budget-wise.
And the other thing that Grace just said is we only are able to get reimbursement for targeted case management work with those clients that are MA eligible.
Mm-hmm.
So we have clients that are not MA eligible that we are still serving.
Absolutely.
Because they're of the resources that are available here.
And they have that need. They have a need for whatever service it is. So we don't refuse services based on whether or not they qualify for medical assistance. In every instance that we can, we encourage families to apply for medical assistance. Sometimes they can have both a private insurance and a medical assistance if their child is in out-of-home placement, perhaps. But that is a big variable in our billing mechanism.
Commissioner, what did you?
Yeah, thank you, Madam Chair. So just to help me understand, and maybe, Yaffa, maybe you said this, so our reimbursement is inversely proportional to the number of actual hours that you all spend with, and that's because the fewer children you have, the more startup time costs and things like that that's involved, or is there any sense to it, really?
You're trying to make sense of it.
I'm not aware of it, so.
Yeah.
Based on percentage of staff time spent on the activity times the average monthly cost pool, which is all our staff costs, our purchase services, administrative costs. So basically the cost to operate the program, both internal resources and external resources, and the money we spend on assisting clients, divided by the average monthly number of clients served.
So it seems like if you have more clients, but you only have one person doing that work, your rate goes down.
And
If you have fewer clients and you have one person doing that work,
Rate goes up?
your rate goes up.
yeah,
So sometimes adding staff isn't, or reducing staff isn't a way to,
Reduce the funding.
yeah, if you
Because you
add
get less.
staff, you'll get your
Your
get
revenue's
more
less.
funding. But if you had too much staff,
then you don't get enough funding.
Yeah.
So.
Well,
And
Right.
so, what they told me at the conference I was at, where we were given all the rates for the coming year, is that our child welfare had a 37% increase in cases. Our children's mental health had a 43% increase in cases. These are cases that are eligible for MA. And for adult mental health and the VADD, vulnerable adults, developmental disabilities, the hours almost doubled and there was an increase in cases, and so that rate actually went up from $755 to $888 a month, and our rate over the last 5 years has been between $700 and $800, so the $888's highest rate in the last 5 years. And I think there was 2 years ago, when did Julie start?
2.5 years ago.
Right, so I think getting her up to speed and has helped. And for the children's mental health, where our rate went down, and it's still within the average over the last 5 years, but it went down $183 a month. I was talking to Lynn and I said, so if you're spending a lot of time on the road traveling, seeing clients that are in out-of-home placement, and if you're spending a lot of time locally, are you making sure that not just your 40 hours a week, but if you put in any overtime, that you're recording all of that in the time reporting system? And he said, yes, I do. So it isn't like he's just putting in his 40 and not any overtime, he's putting in all his hours. And so he's spending a lot of time with clients. And so our rate went down because he's spending a lot of time with clients. It's just like, so is he spending enough time with each client? Should we have another staff person so they can each spend more time with clients?
Okay, yeah,
I
that's
don't know. So,
It's a pretty complex formula.
yes.
Yeah.
Yeah.
This is the most complicated job I've ever had in 30-some years of doing accounting, because there's so many variables for every little piece, and there's so many different pieces, and so it's just amazing.
Good luck with that. Commissioner Gamble.
Yeah, thank you, Madam Chair. Just quickly, Yaffa, yeah, it seems counterintuitive. I mean, when we have other discussions and we're looking at just being overwhelmed with the amount of work that it takes to comply with mandated requirements, and are we being compensated for that? In this situation, it seems that there isn't a reflection of compensation for the investment in time, that you get penalized because of efficiencies and to some regard. The other thing, I think the statement that you made was that, I mean, in public health human services, if the whole world is healthy and we didn't have somebody come and knock on our door, that'd be fine. In other words, if we work ourselves out of a job, we'd be comfortable with that. We know the reality isn't going to be that, so we have to manage the unknown. So that brings me to my question, that in your review, you say the 2017 budget was adjusted for this targeted case management. How did you adjust it?
I used the new rate, And then I threw a dart of where it would be July 1st, 2017, looked at the average over the last 5 years, looked at where we've been, and basically went back to the rate from 2 years ago and used that, close to that for the second half of next year. And then I looked at how many clients we have now and how many clients we had last year and picked a number somewhere in the middle, because we have a larger number of clients in some areas, and then in other areas, the numbers are relatively stable. The people might change, but the numbers are relatively stable in how many clients we're serving. And so I just looked at the rates and I said, okay, so where's it gonna be a year from now? Is the rate gonna be up, down, it's gonna be the same? And I budgeted somewhat conservatively. If it went up $133, did I say it was gonna stay up there? No, I didn't. I said it's gonna go back down some because it's the highest it's been in 5 years.
So
I
the
basically-
income and expense levels as to what you see and what you're projecting, the difference we'll see as commissioners in the budget relative to 2017, on the income side and the expense side, what's up and what's down?
The child welfare revenue is going to be down. Children's mental health revenue is going to be down. The adult mental health revenue is going to be up, and between the two, it's going to be down overall in the mental health area. And the VADD population is very small, and so that's just a very small, less than 1% of the overall budget, so that's not a big factor.
Thank you.
So
And
I'm
that rate went down.
I'm still confused by that. So what you're saying, the overall revenue is going to be down? Or the revenue per person will be down?
Overall, the things that have the higher case counts, the revenue is going to be down.
Overall.
Clients served.
Even though there are way more clients, like 37% more child welfare.
Yeah, but if your
and
rate's down
42%.
20%.
Yeah.
And if you don't
You'd have to be
anticipate,
up.
you know, how many clients you're going to have next year, same as
Right.
this year. And then looking at being in meetings with people, talking about where their case counts are going, and talking with Grace about her colleagues and their discussions about where trends are in terms of case counts. And trends we're seeing here are trends they're seeing throughout the state and throughout the region in terms of
High demands for services.
So, Madam Chair and Yafa, then you're projecting that revenues will be down on the expense side. What are you projecting?
Mental health, children's mental health expenses will be way up.
Okay, so in other words, there's going to be a discrepancy between the revenue side funding the services we provide?
Yeah,
Okay, thank you.
yeah.
Wow, that's a lot.
I just want to thank the work that Yafa
Yeah.
did. She and I work very close together, and Allison McIntyre is involved in that as well, because making sure that people are MA eligible is a big part of our work. So we have to work really closely with income maintenance, and then also with the reports that Yafa submits, she can determine whether or not we've captured all the revenue we can. So we do everything we can to maximize revenue that there is to maximize. We can't control what it is, but at least we can control whether or not we're accessing it. So we work really closely as a team in doing that.
That's great.
Thank you.
Thank you. Any other questions? And Yafa, are you still moving on in your report, or are you?
I've talked myself out.
Okay, that's it. I think the gist of
That to me
what.
was the most important thing to talk about, the change in
Yeah.
those rates, and that just, once again, talking about, you set a budget for the year, and then halfway through the year, oh, by the way, here's your new rates, your revenue's half of what you expected. It's sort of difficult.
To give us a little heads up.
Yeah.
Yeah.
Tempered words.
Yeah.
Wow. Yeah. That's just, yeah.
It's baffling.
It is baffling. Yeah.
So finding that right balance between number of clients you're going to have that you have no idea how many you'll have, whether or not they'll be MA eligible, and how much staff you need, and how much time to devote to each client, and how much time there is to devote to each client. With everything else that's happening, you get a call about possible maltreatment, and you are off and running for the next day or 2 or 3 or however long to determine whether it gets screened out or screened in, and then Now you've got another client perhaps, maybe you don't, maybe it's reimbursable client, maybe it's not. I just applaud the work that all our social workers do, because you can plan your day and it might not ever
Happen that
in a
way.
way. And the days you do, it's like, great, and then there's all the paperwork that
Yeah.
I'm expecting at
Oh,
the back
yeah.
end, the state's expecting at the back end.
Just to clarify too, the time that's spent on receiving a report or receiving a referral and assessing, that is not reimbursable. It's only reimbursable when we move to what's called case management. And that has, in the children's area, for child welfare, a child needs to be in need of protection or services, but in mental health, the child needs a diagnosis that qualifies them as severely emotionally disturbed in order for us to draw down those dollars. So you could work with someone for 3 or 4 months before you even start capturing any revenue, because you need that diagnosis, otherwise we'd be out of compliance. So that's another interesting variable, is the whole assessment phase is not reimbursable. So.
Okay, thank you. That was
Thank
a
you.
lot to process, and I really appreciate your patience and articulation and explaining it to us, because it really is it's not just counterintuitive, it's beyond that. It's the layers of complexity are, yeah.
You need to put it on this finely tuned scale. Let's see, where does it balance the best?
Yeah.
And then you get another phone call and it's,
Yeah, sort of, yeah. Greg's report sort of feeds into this. It's really out of our control. It's really out of our control.
And
So-
again, in the end,
But
you
we
have
are
to provide
forced
the
to control.
service regardless of,
Yeah.
with the revenues. Yeah. That's your obligation, obviously.
Yes. Well, thank you
Thank
very
you.
much. So, moving on to our new director, Joshua Beck's report and introduction.
Well,
Telling
at
stories.
first I was thinking, I told all my staff, I was like, wow, I don't have much for this first meeting. I'm like, they're all gonna look at me like it's like a 20-minute meeting. But now that we're an hour in, I'm thinking, okay, this isn't so bad. So I don't have to go into as much detail about myself. But since I believe Jan was the only one that got to formally meet me during the interview process, I just wanted to kind of talk a little bit about myself. We'll just do the background that kind of relates to the job. So I actually I went to Purdue University, got a degree in exercise science. My first job was at the Dayton Heart Hospital doing cardiac rehab for we reached income sensitive portions of the population, so mostly grant and donation based services to people that couldn't afford cardiac rehab otherwise. I did that for about 3.5 years, ended up being the manager of facility there. And then kind of, Greg's not here so I can tell him, but I was one of those people where direct services was just really difficult for me. So, working that one-on-one, the recidivism, I can't even say it, but it really takes its toll on you when people come back, and especially in cardiac rehab, when they go through that kind of a life-changing event, those first 6 months, man, those people are just gung-ho. They're going to change their life. And as a new person working in that field, you're like, hey, I'm making a difference. And then, you get to year 2 and 3, and you're starting to see the same people again, and they're going back to smoking or the way they were eating before. And it kind of really takes its toll on you. So honestly, Grace and the social workers and Greg and all of what they do it's pretty amazing to me, because I kind of took the opposite route. I started looking for jobs that did population health. So I ended up moving to San Antonio, Texas to do I was when Texas was, I went there right when they were labeled the worst, the fattest state. So, with public health, that always means that's where the money follows. So I took on a new grant there when they were rolling out a large cardiovascular disease grant in the state. One of the main things we were doing is the President's Youth Challenge that you guys probably all did, that I had to do when I was a child, sit-ups, push-ups, whatever. They kind of expanded that. Texas is one of the states where it's mandatory in all schools from 3rd grade to 9th grade. They take measurements every year It's where we get a lot of our really good data nowadays, because we get to see they matched it to, used unidentifiable data and matched it to grades. And so we get to see, we have this really great track record coming from the data in Texas that the kids that are the healthiest have the best grades. The kids that are the most unhealthy have the worst grades. And we get to see those trends. And so it was a really good experience working there. It kind of taught me population health for me was a lot better. I'm a numbers guy. Like I know Gary and Frank are. I've been watching all these meetings for all the ones I could watch on YouTube. And so it's really neat for me because I'm a numbers guy, so I like to see those numbers. And with population health, if I change, 1% of all the population, or even like 0.5% in these larger areas, I'm still doing more than what I felt like I could do with that one person. So, but a lot of that was also, my cop-out, because it's hard to go through the struggles that, staff goes through dealing with clients one-on-one that might have to come back or whatever. So after being there for a little while, I went back to Purdue University, did a master's degree in public health. Actually, I went back to a doctorate in public health and realized somewhere along the way that, and everyone kept asking me, am I doing it for pride, or am I doing it because I need it, because I knew I wanted to go back to government work. So I like to say I have the longest master's degree in history. So after 4.5 years there and more credits than you would ever possibly need for a master's degree, I finished with a public health degree there. One of the greatest things I learned while being there was I got to teach because of all the work that I had done. I got to be a continuing lecturer and a graduate teaching assistant, kind of both there. And so I got to teach a couple classes of exercise physiology, which is a 600-person lecture hall. So it really helped me with public health, public speaking in general, but more than anything, that whole school was always pretty easy for me. And I think it's really good for people that have school. It's always really easy for you to have to teach, because it really forces you to remember and learn how to teach the people and see, we always said seeing that prism from each side, that, everybody can get to the same place to see the same image, but they're all going to get there from that different way. So I think that helped me just in general of management and how you manage people. So at that point, I kind of moved us out to Arizona. So I know if anybody saw what's this person from Phoenix, Arizona, want a job in Cook County for. So my wife graduated from the other school in Indiana, IU. And her degree was in art education. It was right during the, when everything crashed. The normal thing in teaching, most of the time is you usually teach, you do your student internship somewhere, your student teaching, usually that school hires you. Well, that didn't happen right then, because everybody that kind of graduated in that 3 or 4 year period wasn't getting the jobs, because the student teaching jobs didn't lead to teaching jobs. So eventually Arizona was one of the states where she could find an art education job. I had enough background that I was kind of willing to go wherever she went and would be able to find something. So us Midwesterners moved out to Arizona thinking, here comes the sun. And that's what led us out there. So I worked for Maricopa County, the second largest county in the United States by population, where Phoenix is. I went out there as a management analyst. I had a big numbers background, so I worked underneath the deputy director and the division administrators, basically looking at a little bit of background. I don't want to go too long, but so Governor Ducey had just come into Arizona, and he's very large on lean transformation, Six Sigma, performance management, and so we had that going along with the big trend in public health right now is accreditation of all public health departments in the United States, which really kind of goes along with that. It's all about lean transformation, performance management, outcome driven, making sure that we're seeing the best results we can from the money. So I got to spend basically about 2 years there looking at all the different grants, how we spent our money, the most efficient use of payroll, human resources, how we were spending our grant money, were we using evidence-based practices, these kinds of things across all the grants, which what inevitably happens is, and one of the other counties found out all the things I'd been doing. Everyone knew that I kind of wanted to go more rural, not a big city guy. So I went out from there to the second most rural county in Arizona to be a division administrator of public health, to run all public health programs. Throughout doing all this, as I told Jan in the interview, I like to contribute more than just what my job can usually entail. So I was part of I volunteered at the beginning for the Public Health Board for the state. Started out as a director at large, went on to be vice president, president to be a president-elect, and then currently right now, I'm still technically president until September. They didn't kick me out when I left the state, since I only have a month left. But so the last 4 years I've been spending as on the board for the Arizona Public Health Association, and that's been a really good experience. Obviously, learning how the legislation works. We have a lobbyist, so I've had the experience to work with bill writing, working with our representatives and stuff. So just a really good experience. But what that also taught me was that I kind of got so big picture looking at the state level things, and in Arizona, you know, we could say everyone's transient, no one's from the community, so I missed that sense of, you know, everything I was doing was for all these people that wasn't where I necessarily live. So when we saw the position here, and I'm sure everybody's probably seen the newspaper article, my wife's family actually has history here too, so it wasn't a complete, you know, shot in the dark just to get back to the Midwest. We had the history here, so we wanted to come back to an area we knew, so when I saw the position. But a lot of it too was, you know, I wanted to get back to where I could be part of the community that I lived in. So like take the experiences I had with working on public health legislation and working in public health and doing these things, but actually being in the community so that I can make a difference with the people that I, you know, live and work with. So that's what kind of got us here. Again, why I've been enjoying the staff so much. So I don't know if anybody has any questions about what got me to this, but I'll at least give you a second.
Commissioner Gamble.
Welcome, appreciate the overview. So the P-TITAC, what's the story on the P-TITAC?
No idea. What
Public
was that?
health.
It's either public health. Well, Purdue
Is it
is
a
what
P?
I sort of thought.
Oh. Oh, yeah, that's the, so it really was just a really good night we had at the, believe it or not, a lot of people from the Midwest go out to Arizona, so I was part of the Purdue Alumni Association out there, so I got the little P-TITAG, and so I've been laughing since I've been here because I've already noticed the Minnesota and Green Bay Packers thing going on upstairs, and I had the little Packers logo on my door, and so everyone's asking me which side that I go for, and so I'm like, I just stick to the colleges, so you'll probably see lots of Purdue stuff in my room, in my office, so you'll see the Purdue stuff up there, so that's why. And then I always had fair warning, it's not the Pirates, because it's the same logo, basically, so I'm not a baseball person.
Thank you.
Thank you. Thanks.
Thank you.
Okay, so then I guess the next thing for me, like I said, I like to always be prepared, so I've been watching most of the last 4 or 5 months worth of the board meeting. And just kind of curious, you know, are there any extra board expectations, or are there other things you would like to see from us, or, you know, as we're planning out our meetings for the next year, what are there things that we're missing? The current status quo is good. Are there other things you would like me to bring to your attention, or levels? You know, are we going deep enough when we do our presentations? Which, based on Greg's, I would say, yeah, we are. You know, just real quick, if you could give me an idea of what you would like to see from us. I'll start with you.
Yeah, thank you, Madam Chair. Again, welcome, Josh. I'm glad to have you here. There's, as you've realized already, and probably through the interview process, the magnitude of this job and the breadth of information that you're going to be expected to master. I think we all have different takes on that, but specifically, my first concern would be the staff that you're responsible for. I think all the positions in the county are difficult. However, we've had some turnover in staff that you're responsible for, and I think largely that's normal in the profession, but it's also very difficult work. And we've wrestled with what are the things that we can do to make that less, to create some kind of additional support for the staff members who have experienced crisis, you know, in their work with people with their clients. And so I would just ask that of you to keep that first and foremost in your mind. How can you alleviate that stress load? How can you make that as easy as possible for those people that are doing what I think is the most important work that we do here?
Commissioner Gamble.
Thank you, Madam Chair. I would concur with Commissioner Mo's comments, and I think, based upon the little overview that you gave us, that it takes an individual who sees those needs and identifies with them, because you will commit yourself to nurture staff if you believe that that's important. And if you've watched, some of our previous meetings, and whether or not we've had our Public Health Human Services meetings available to view, but it's been grueling. It's been grueling because of the human cost in trying to deliver services for human need. And it takes quality people, which we hear that affirmation in a lot of the presentations as to the quality of our staff, the commitment of our staff. But there's a financial component, there's a regulatory component, and I think that your drafting legislation, your awareness and exposure to that is hugely important, with all the things that are tasked that come by way of mandates and those requirements for human need. Being an advocate to try to change those things that we just had a lengthy discussion about, how we calculate this and calculate that, how we don't include this, and the realities of what we deal with should be clear and understood by those that make decisions that affect our ability to be both caring of staff and fiscally responsible. And so I think that the advocacy that comes in drafting resolutions or legislations, encouraging legislations and sponsoring and getting coalition of people to do that is going to be a huge part of not being isolated and having to manage things, but being active in having a voice that tries to change things that impact our staff. And I think if they see that there's leadership and representation with that commitment to empathize and come alongside is a huge part of building a culture that's important.
Commissioner Sterling.
Thank you, Madam Chair. Staff support is very, very important, yes. Also getting to know our representatives, like Rob Eklund and Senator Bach would be important, because there'll be meetings that you'll go to that they perhaps will be there or not, and then once you get to know them, they'll know who you are, because they really like our county. So that would be important too, to get to know them.
This just feels like maybe, Commissioner DeKirk, did you have anything you wanted to add? I mean, we could just go down the line, but I know Jerry had his hand up, so if you want to think about yours, we'll go to Jerry. And I just don't want anybody to get left out of this part of the conversation, because he's going to use Commissioner DeKirk's method here. But I'll skip to Jerry, and then we'll come back to.
Okay,
Yeah.
thank you, Madam Chair. Carla and I are here as representatives of the Public Health and Human Service Advisory Committee. And I really feel good about the relationship between that committee and the work of that committee, and then our linkage to the Human Service Board. The meetings that we have on the advisory committee have been about looking for the gaps in services that may exist, and looking for the difficulties in providing services, and so asking the question, well, how can we support, how can we as a group of citizens and providers on that committee be supportive to what the agency is doing? And sometimes it's amazing to see the interchange between the people on the committee and the ideas that come up, and connections that get made between various members. Other times there'll be some issue that we will say, this is really important. We think we'd like to have a resolution that we can then carry up to this board to bring it to a higher level of attention in the county. And so I just want to say, I think it's really an important committee, and we feel, I think I can speak for Carlos, and we feel very good about being on that committee, and would look for you to be a supportive director in your role with our committee.
Okay.
Commissioner DeKirk, did you want to?
I don't know how to say it. I think everyone on this committee supports the work of public health. But what's not being said is you're gonna have to make their jobs better without spending any money. Just gonna be a tough job.
Yeah, and I think we heard that today. It's a complex scenario to balance all the,
Yeah, we don't have money as a county, and apparently the state doesn't give a crap to give us any money, so you're gonna have to try and make people's lives better without spending any money, and so far we haven't figured out how to do that.
Sometimes P is pathetic, sometimes P is perseverance, sometimes P is patience.
but P is a good letter.
Yeah,
I get enough of those jokes from my Hoosier wife.
yeah, right.
And sometimes P is piss on it.
Right. Okay. Carla, that's a good lead-in.
I don't think I have, anything to add, but to echo the sentiments, everyone, and we welcome you and look forward to you. And the only thing I can say for our advisory committee is that we have struggled in recent months to get people representing different geographic areas or who have been in some way clients of these two agencies or their relatives or some experience like that. We were really kind of desperate for that type of candidate. If you meet one in the grocery store.
Yeah, it's a challenge. And so, and I don't want to leave Jeff out either of the conversation. Jeff, do you have any insights you wanted to?
I think we're very fortunate that we had Josh in our applicant pool. I think we're going to see that he's going to bring a combination of the best values that we had in his predecessor and a fresh new look into the Health and Human Services Department, and I'm just excited to work with him.
Great, thank you. I'm excited too. I didn't necessarily weigh in on this, but as a relatively new commissioner, I struggle with all of the variety of boards and commissions and that relate to health. And I think for me, it's just hard to know what to focus on. But I think as I get more acquainted with all of that, to have some specific goals is probably what I get frustrated with, to be able to work on and make progress with, to see that we're making progress in certain areas, to focus on certain things. And I think, as you mentioned, Jerry and Carla, about the advisory board, a lot of that comes out of there, because that brings a lot of pieces together. All of these committees bring a lot of pieces together. So I hope that we can bring the pieces together and create some strategies to accomplish some of these things, even though we don't have any money. But even maybe even accomplish that, get more money. So that would be a great accomplishment if we got more money. So I'm really glad you're here too, Josh, and grateful for the wonderful department of staff that we have, and that's what you said about staff is really, really, really important. The staff deals with the most vulnerable of our community at their most vulnerable, and we all know that's the hardest time in everybody's life, and it's really hard to take that role on and not get burned out. And so if we can somehow think of creative ways to alleviate that with our staff. Yes, yeah.
We were giving a lot of kudos earlier in the meeting to the social workers, but I think Allison and her staff that also works with clients who are in financial crisis and food crisis and are coming for help. They're often working with the same clients as the social workers or the court system, and sometimes just working on clients that aren't interacting those areas as well. So her group needs kudos as well. And also our public health nurses that do home visits with prenatal, postpartum visits, well baby checks. They're working with clients too. And I'm one of those people who sits back in the corner and pushes paper.
And sees everything,
Yeah,
and
a
sees
lot
it
of
all.
it.
Yeah.
So I just
Yeah.
want to give kudos to the other
Yeah.
people as well as the social workers
Thanks.
for working with clients and the stress involved in
Yeah.
that.
Yeah. Awesome. Well, that's a huge order. We just added to your.
No, you're fine. I was going to
Yeah.
respond to a couple of those
Yeah,
real quick.
great.
The first one just being, so one of the great things of being on the board for the Health Association for the last 4 years is you'll learn that I have a very very happy attitude towards reaching out to my representatives to inform them, and I'm quite used to doing that. And you know, one of the first things I did because of the relationships I had in Arizona was reach out to your public health director through our public health director for the state, so that hopefully I'll be attending the conference in late September for your state health associate, your state health that the state puts on, and having lunch with Ed Ellinger. So I'm already trying to establish those relationships and make sure our little voice is heard. And then the second one that we've talked about in our management meetings already, that as you guys have already mentioned, that I think is on the list of all of my scribbles on every paper from every meeting I've had so far, is that turnover word circled. Because yes, and like what Commissioner Moe and Gamble said, it's like, wow, I'm always used to turnover being an important thing that, you know, we're always trying to mitigate. But gosh, even in my public health world, you know, if I take someone with a degree, a lot of times, and then most of the things I've managed, you know, usually I can get somebody off the ground and running, and you know, if they have the basics in like 2, 3, 4 months, they, you know, I may not have an optimized employee yet, but you know, I can usually get them off the ground. And kind of like what Yafa was saying, there's a reason Allison's still here right now, because to give her committee updates and her legislative updates, is she does so much that I pretty much have to bring her in here, because it will take, I feel like it will take me, with all the experience I have, a good 6 months to a year to understand even the depth of what Allison does, because there are just so many programs. And, you know, I've talked to her and Grace about, you know, it really does seem like 12 months to 18 months before somebody is fully functional in those positions. So, yeah, I kind of immediately got to the same place you guys were at. I'm like, if I can't pay more money, but, you know, I always look at one thing, you know, quality improvement and all the things I've had to do have taught me is, you know, we're always looking at the money and the man hours, and, you know, you can't help but see that giant, you know, highlighted area where you think to yourself, I can't afford turnover, because that, you know, if I'm trying to save the citizens and I'm trying to save the board money and I'm trying to keep a good environment for the workers, like I can't afford turnover if it takes that long to. So if you hear anything from me over this next year, I can tell I'm a very, like, as Jeff and I have talked about, sit back and really observe and learn in these first 6 months. But yeah, that's clearly like right on top of the list right away, because I realize the importance that that's going to have on all of our staff. So, and those are the two, I think. Answer. So do you want to move on to staffing update, which is really easy. I just threw it on here because we have the one position open right now. I'm trying to think what it is. You guys can help me.
Office support specialist case aide.
Correct.
For that part-time position when Janine reduced her hours, and we're gonna backfill that. And the first test was several months ago, and we reposted the job, and the testing was last week, and later this week we'll find out which of the people who tested passed the test, or if all of them did, and then schedule interviews. And so it'll be the September board meeting where hopefully we will have a recommendation for hiring someone to fill that spot.
And then, so I have one, I'm going to skip legislative because I'm going to have Allison do them, but I have one Region 3 update, which is the Adult Mental Health Initiative is going to be conducting interviews of service providers in all the counties to kind of look at the overall picture for mental health, starting with the Birch Tree Center, but also looking at all crisis response. Grace was nice enough to give me the report that they did, I believe it was 5 years ago, the last time they did this around. They did an excellent job, from what I read, of questioning people, you know, both ends of the spectrum, the providers and the clients as well. If it's as good as a report as the first one was, it's kind of nice, especially for me being at the beginning, because I kind of get this great snapshot of where the issues are and where the strengths are right off the bat. So, but that's going to be happening here over the next 6 months. So, and then Allison, if you want to go ahead and do yours.
So Josh asked the supervisors if we had any legislative or Region 3 updates to give, and I was just here last month and gave a pretty extensive presentations, but of course there are changes in the meantime. So a couple of the things that I wanted to just highlight were related to legislative changes that affect the cash assistance programs effective August 1st. There are changes to how the agency is able to collect on any overpayments. So if a family or an individual receives more benefits than they're eligible for, If that error was a result of the agency not acting timely, misapplying policy, then that would not be recoverable as of August 1st. So we're still required to set up the claim, to cite the overpayment, but the agency is no longer able to actively recover that overpayment. And that's just for the cash programs, general assistance, Minnesota supplemental assistance, MFIP and DWP, the family cash programs. So that doesn't apply to food support or to medical assistance.
Madam Chair and Allison, if I could just ask in that regard, what would you say our exposure is in that area? In other words, if there's been a provision where if an error internally, we've been able to recoup in that regard, when you shore up services and you have accountability and things, and you track things well, and you don't have that exposure to internal, situations where we haven't acted properly or aren't in compliance, then our exposure wouldn't be so great. And normally when something changes like that, where we have increased exposure, then we start to look at our processes in a way to make sure we don't have exposure. But I'm just asking, based upon our experience, what do you think our exposure is in that regard? Go ahead.
In all honesty, this has been an area where we haven't focused a lot of our time and
Okay.
energy as a department. When we see an overpayment, typically we'll just identify it as such and not set it up or actively recoup it, regardless of if it's household error or agency error, and that's just because of the workload that we've had.
Okay.
Another change that went into effect is that the 2016 legislature proposed changes to estate recovery. So families began receiving notices, individuals and families began receiving notices on August 1st about those changes, and that is pending federal approval, but it would apply retroactively for any MA services provided on or after January 1st, 2014, that counties and the state would no longer be able to recoup the cost of services paid by medical assistants for enrollees at the age of 55 or older. And this doesn't apply to any long-term care services or supports, so waivered services or anyone who's in a nursing facility level of care. And again, that's just effective January 1st, 2014.
Any questions?
Just a question about that. So, did we have any residents in Cook County who contacted you and said that was an issue for them, that the state was going after their estates? Okay. And so, and then you communicated that with them, and I'm sure they're relieved.
The state sent out the notices and we're starting to get calls now.
Oh,
as
you're getting
people have
calls from them.
questions
Okay.
about the specifics of that change. Yes.
Great, thank you.
So I'm confused. So the state will go after the estates? Or that as of August 1st, they can no longer?
As of August 1st, the county and state are no longer able to recoup from the estate
Got it.
of someone who received MA services when they were 55 or older after they die. And that's an important thing I should mention too,
Yes.
that this is
Right.
post-death.
And prior to that, they could, and now they can't.
And they will still be able to recover any costs that medical assistants paid prior to January 1st, 2014.
Got it.
So some of the reaction was the lack of transparency people felt about applying through the Medishare exchange, that those provisions weren't explained to them when they applied, or
Right.
but
Right.
it has been in effect since 1967. Minnesota has one of the oldest estate recovery programs.
Okay.
Did they change the criteria? No, they changed it back. That was my understanding of what they could take in estate recovery. That it used to just be long-term care, and then it changed before the Care Act.
No,
It
that,
changed back.
no, Minnesota has always been able to recover the cost of care for anyone, any MA services, regardless of if it's long-term care.
Okay.
That didn't change in January. That's always been the case.
Okay, but now it has changed
Yes.
as of
Pending federal approval, yes.
August 1st.
Yes.
Okay. Thank you. Yes.
Of pending approval. It's
Yeah.
just hang out there for a couple
Yes.
months.
Hopefully know what's going on.
Thank you.
Thank you.
All right.
Okay, well then, I suppose the only other thing I had, but I'm not going to go into it now because I think we went long enough. So, and I just received this, and I think Jan just received her copy as well, the Bridge to Health survey. So I don't know if you guys have received it, but I will have it sent out to everybody so that we can discuss next time, because there's definitely some good aha moments as you read through here. I think that'll give you guys a chance to go through, and we can hopefully talk more about it during the next Human Services Board meeting. And we'll be able to talk it on the advisory board too, to kind of go through and see what we see. But it's been a very helpful document for me because they did a really good job with it. And somehow you guys did an amazing job because Cook County had the most survey respondents of
Yeah,
all the
we won.
counties, which is pretty amazing.
Really?
And,
Yeah.
And so, you know,
Some-
again,
And they didn't
number-
even mail us $1?
They did mail us $1.
Is that the one that was?
Oh, yeah, that was the one that mailed you $1.
Okay.
Yeah.
Perfect.
Maybe there's why. But, you know,
Yeah.
Oh,
so-
no, we love surveys up here.
We love
So
dollars.
again,
We love dollars.
So again, I'm sure, you know, so I'm always, you know, anytime you do surveys in small rural communities, you're always worried about whether you're in, you know, the amount of people that play the survey are enough that you can even care if the numbers have any significance. But they did a great job with this survey. They took out any questions that had less than 30 respondents only for questions. So it's pretty good data. So I just recommend, you know, I'll send that out to everybody and, you know, you have it so we can kind of go through this in the future.
And it is really good data, but at the conference, they did explain how they've collected the data has changed through the years. So if you're doing data comparison, it doesn't necessarily play out exactly as you would expect. So if you're trying to compare this statistic to 5 years ago,
Yeah.
when they changed how they collect the data, it dramatically changed the results. So, yes.
Thank you, Madam Chair. Just a
That's
quick
excellent.
comment that sometimes response to surveys, when you look at the demographic relative to age, that there's a sense of responsibility and obligation when you have an older demographic in regard, or an education is another component when you're looking at demographic as to response or long cold winters and nothing to do.
Saving that $1 for a nice moment.
Well, that's actually, you know, one of the first things they do, I kind of like, because they break it down very well on some of the pages. At the very beginning, they break down their sample across the ages and the genders. And so, you know, you're really quickly be able to pull up the census for this area, and I was able to
Yeah.
compare it. And comparatively, you know, they did a really good job of getting the correct size sample for each one of the age brackets, which, you know, a lot of times can be difficult. The you know, 30 to 50-year-old men just rarely respond to surveys, and they did a pretty good job of getting a nice consistent
What do you like
sample that
dollars
matches
to?
up with the demographics of the county. So
So,
that's all I have.
great. Well, thank you and welcome, and we'll look forward to lots of great new work. And so what I'm hearing is maybe that Bridge to Health survey would be on the agenda next Human Service Board.
Mhm.
That would be awesome. We could talk about that. And that would help me with my, you know, to focus on what our issues really are. I'm having a hard time. What are our issues? But that's great. So we'll move on to no items for board action today, but committee reports, starting with Arrowhead Economic Opportunity Agency.
Meet tomorrow.
Okay, and is that always the case?
Not always the
Okay,
case.
that's
I think this is the
yeah.
first time it's been that close.
Okay,
But
good.
it's the way the stars aligned.
Yes, excellent. Arrowhead Health Alliance did meet last week, and Josh was there and got to meet some of the other, there was an acting Public Health Human Services Director from St. Louis County, Linnea, can't think of her last name, but she was there. It was fun to meet her. And Dave Lee was there, which was awesome, and Josh got to have some good time with him. And but I would say that the most interesting thing we talked about was we talked about this idea of a triage center to alleviate all mental health people ending up in hospitals and emergency rooms, and sometimes waiting there for hours, if not days, if not weeks, and the real issue that we have with that. So there will be a lot of agencies gathering pretty much around St. Louis County to talk about this crisis. And yes.
Does that include the ones that end up in law enforcement?
Yeah. So there will be people sitting on this committee, it's evolving, from all of the all of the walks, hospitals, government,
Judges.
law agencies, judges. I mean, it's a really comprehensive, inclusive group that's gathering around this idea. So it doesn't necessarily mean bricks and mortar, but just what changes can we make at that beginning level to alleviate all kinds of problems that we have, which is really exciting.
Well, we didn't get to hear much about it, but they also
No.
mentioned the early stages of that $500,000 RFP that's going out, remember, to work on helping provide more services locally versus, down in Duluth or St. Paul. And they didn't give us a lot of detail yet, so I assume it's not actually out, but something we might
Yeah.
look forward to that David seemed pretty interested in, so.
Fantastic. And boy, I just, because David is our only one left with that experience, I think we'll be kind of clinging to Dave for that kind of support and information and help us in our choosing what we need to work on. The other part that we talked about, which has been an initiative launched by AHA, the two initiatives, the Birch Tree Center, which is awesome, functioning really well. And now that we're doing our own crisis intervention, answering the call locally, I think that's working really well. But the DHS, the video process is working really well. So far, we have about 100 video locations in the region, and it's being used in profound ways. And one of the things that AHA is going to do is to invite the Department of Health to actually show up for one of our video conferences, and it will be with Grand Portage. So on October 6th, Roger will be on that end, and St. Paul will be at that end, and they'll actually be able to see it working, and then maybe become real believers in the, evidently they're having a hard time grasping the importance and the significance that this method of tele-mental health is really helping this region. And so I think having them sit in and really experience, having a real live experience of this process is going to help everybody. So the goal is to eventually get all 400 access units set up in the next, I don't know how many years, but so far we have 100, and I think it's working. Everybody's really excited about it. It's working really well. We've had good results here. And so that's what I have to report on Arrowhead Health Alliance and Arrowhead Regional Corrections.
Be done Friday.
Okay, wow, your reports are really
You're allowed to say next month.
Yeah.
A lot extra time.
Yeah. Okay, so the Community Health Board did meet, and it was really interesting. The topic of the day was public health emergency preparedness, and they got to speak from their real life experience in the last, I guess it was 4 weeks ago, they had the huge storm, and so they got to report on their really live experience, and it was really nice to have Josh in the room, who, that was your thing.
I guess I didn't say much about that in my introduction, did I?
Yeah, and that he is also an expert in public health preparedness.
In Arizona, emergency management, because of the similarities and how close the funding is related, deliverables are related nowadays. Public health emergency preparedness and emergency management are grouped together, and we usually run those through the health department. So inevitably, if you guys heard much, I got to go through 2 measles outbreaks over the last year. One from Disney came to Arizona, and we just had one in our regional correction center where we had 17 inmates and 8 staff that spread it to our, fortunately only had 4 in the community receive it, but we had like 13,000 contacts we had to go out and do contact investigations on. And I've been through 4 forest fires and 2 floods, so I kind of got baptism by fire as an emergency manager, because in most of the country, everybody's still running it different, but emergency management and public health preparedness aren't usually something that's always grouped. So, but it gave me that experience. So hopefully, when you guys are able to bring a new emergency management person on, if they ever need anything, I'm happy to reach out and help them with the experience that I have.
Yes, Commissioner Gamble.
Yeah, thank you, Madam Chair. To that point, County Administrator, if with our interview committee, whether there had been any thought given to maybe including Josh on that interview committee as a suggestion for our new emergency manager.
We'll have an update on that during our next meeting, our board meeting.
Okay.
And
Awesome.
yeah, we're aware that Josh has much to contribute to.
Yeah,
emergency
if there'd be
management.
benefit.
Yep.
to-
Mhm.
yeah.
But just to follow up on so this meeting was dedicated to really listening to this, one of the public health emergency people who worked with this last storm. And as we've all seen in the news and so forth, our storms are, in the United States, are really heating up and becoming more and more dramatic. So I think this conversation is something we'll be talking a lot more about. But the one thing that happened in this last storm was it was, height of summer. Everybody's on vacation at their remote cabins with no access to, cell service and internet and all that kind of stuff. So the project was really managed by very few people, but the system worked in St. Louis County, and largely due to a great group of public health nurses who went knocking on doors, particularly in senior housing places. So having that personal attention coming from a real human being was really helpful in those places to allay fears and so forth. But the one conversation, we started to have the conversation then in our just our little group, just about who has generators. The whole idea of electricity being out, the electricity in St. Louis, or in that region, was out for 6 days in a lot of places, and what kind of problems that leads to. And that may be something that could be easily alleviated if we got our act together and had serious generators. And
it was random power outage. My
Yeah.
daughter's on Boulder Ridge.
Yeah.
And so the unit next door to her had power, so they ran an extension cord from her refrigerator to the next apartment to have power. So like
She was popular.
sections of the building had no
Wow.
power, but other sections did have power, so it
Sounds
was.
like my neighborhood.
Yeah. But this was an apartment.
It's only a
This was
light.
an apartment building.
Yeah, that's amazing.
So there's people running cords into the hallway because some hallway outlets worked and others didn't work.
Yeah. So I'm sure we'll be, talking a lot more about our plan, and particularly as we get a new emergency director, and with your input and so forth, we'll be able to create better public health emergency plans, preparedness plans. Next, Public Health Human Services Advisory Committee hasn't met, unless you met and I didn't know.
Next month.
Next month. Healthcare Planning Committee, Commissioner Storley.
Thank you. Well, it's summer. We did not meet.
Okay, very good, very good. Well, North Shore Collaborative did meet, and there was a lot of talk about bylaws. It seems like a lot of organizations are always working on their organization. But I was interested to hear from Human Development Center in Lake County. The Department of Health is working on training for mental health practitioners, which is always a really welcome service. So they will be working on a year-long Train the Trainer series, and particularly focusing on daycare centers, which is also interesting. But they've also been working on people being released from jail, getting them counseling so that they are better prepared to leave, and getting them counseling once they've left. And of course, it's a volunteer situation, not volunteer from the service situation, but people leaving jail can either volunteer to get the service, and most of the people leaving are really willing to accept this help, which also shows that the service is highly needed. And that's pretty much all I have to report. Anybody else have anything to?
It was the Jan show there for a
I
little
guess
while.
we'll see. Sure, I didn't even have it.
Fix that camera, so moved.
Yes. Okay. That's all
County
we
board
need.
meeting will
You're-
start at 10:30.
You're adjourned. Thank you. All right.